Usually when we talk about a medical diagnosis, there is a very comforting expectation of precision and finality.
Right, yeah. Like
Ah.
fixing a broken bone or something.
Exactly. Like you fall off your bike, you break your arm. The x-ray shows that jagged white line on the screen. A doctor puts it in a fiberglass cast, and, well, maybe 6 weeks later you get it sawed off and you are fixed.
Yeah, you're good as new.
Right. I mean, the narrative is totally binary. You were broken, and now you are not broken.
We really gravitate toward that kind of medicine. We want things to be, easily categorized with a clear, definitive end to the story.
Oh, absolutely.
But that framework just completely falls apart when you move away from acute injuries and enter the realm of chronic neurological conditions.
And that is exactly why we are doing this today. This deep dive takes a stack of your sources, the latest articles, clinical research, detailed medical notes, and extracts the most important insights, custom-tailored just for you.
So whether you are a medical student prepping for your pediatric neurology rounds or, a caregiver trying to navigate this overwhelming healthcare system for a loved one.
Or just someone fascinated by how the human body works. You are about to learn how modern medicine tackles a highly complex, uncurable condition, which is cerebral palsy, or CP.
Yeah, and this condition forces us to completely reframe the concept of a cure because CP stems from a non-progressive injury to a developing brain, usually before, during, or shortly after birth.
Right. Non-progressive meaning the brain injury itself doesn't actually get worse.
Exactly. You aren't trying to eliminate a spreading disease. The real challenge is that as the child grows, the physical manifestations of that static brain injury are constantly changing.
Okay, let's unpack this. Because where do we even begin when the goal isn't a cure?
Right. It's a huge shift in mindset.
So our mission for this deep dive is to demystify exactly how CP is managed practically, like step by step, once a family receives that diagnosis.
And the sources lay out this amazing roadmap.
Yeah, focusing on what they call the spasticity ladder, the specific treatments given for dyskinetic CP, and the massive role of orthopedic surveillance.
So to start, the baseline philosophy, the mindset that literally dictates every single prescription and surgery we are going to talk about, is that CP management is fundamentally a team sport.
Yeah, I saw that all over the sources.
Right. No single medical specialty owns this condition. It requires a massive, highly coordinated, multidisciplinary team.
We're talking a lot of different doctors here.
Oh, yeah. You need a pediatrician or a neurologist steering the ship. You need a physiatrist, which is a doctor specializing entirely in physical medicine and rehab.
Right.
Add in orthopedic surgeons, physical therapists, occupational therapists, and speech therapists. And depending on the patient's specific comorbidities, ophthalmology, ENT, psychology, and social work might also be heavily involved.
It totally reminds me of a Formula One pit crew.
Oh, that's a great way to put it.
Yeah, like you don't have one mechanic guessing at everything, changing the tires, tweaking the aerodynamics, and tuning the engine all by themselves, one after the other.
No, that would be a disaster.
Right. You have this highly specialized team descending on the car simultaneously, each with a micro-specialized role, but they're all communicating to keep the car running at its absolute best.
And the overarching goal of that pit crew is maximizing function. They do that by dynamically addressing three main things: muscle tone, musculoskeletal deformity, and underlying weakness.
Which are all totally connected.
Exactly. These treatments, whether they're, pharmacological, rehabilitative, or surgical, they are deeply integrated. I mean, you can't perform a brilliant orthopedic surgery if the child's muscle tone is so tight that it just immediately pulls the bones back out of alignment.
Which brings us to the very foundation of the source's approach, which is the spasticity ladder.
Right. The first step.
Yeah, before anyone even thinks about permanent surgical fixes on bones or nerves, the medical team has to handle spasticity. And for those who might not know, spasticity happens because the damaged brain stops sending the relaxed signals to the muscles.
So the muscles are just constantly firing, they're constantly tight.
And that constant tightness makes rehabilitation nearly impossible, right?
Basically impossible. So run one of the latter focuses on systemic relief. We were talking about oral or sometimes enteral medications.
Like pills or liquids.
Exactly. They are the first-line defense because they are relatively easy to administer, and the side effect profiles are very well understood by pediatricians, and they are perfect for generalized spasticity.
By generalized, you mean whole body.
Yeah, meaning when that debilitating tightness is widespread across the entire body, affecting, both arms, both legs, and the trunk.
The sources focus heavily on exactly what is given here. And baclofen is highlighted as like the most commonly favored first-line agent. So how does a pill actually tell a spastic muscle to loosen up?
Baclofen essentially acts on the central nervous system to turn down the volume of those continuous muscle contraction signals.
Oh, okay.
Yeah, it mimics an inhibitory neurotransmitter in the spinal cord, telling the nerves to just stop firing so aggressively.
But there are alternatives in this first rung, too.
Right. Doctors might prescribe tizanidine, dantrolene, or benzodiazepines. Dantrolene, for instance, works directly on the muscle fiber itself rather than the central nervous system. It interferes with calcium release to stop the muscle from contracting.
The sources also list second-line oral options, like clonidine and gabapentin. And what really stood out to me is that these aren't just muscle relaxers.
No, they do a lot more.
Right. Gabapentin, for example, is often used for nerve pain. But the sources note these drugs have a fascinating bonus effect. They actually help with sleep disruption and neuroirritability.
And that is huge. A medication that takes the edge off muscle tone but also helps a child sleep through the night improves their function and quality of life exponentially more than a drug that only targets the muscle.
Because lack of sleep makes everything worse.
Exactly. Sleep deprivation makes spasticity worse. Pain makes spasticity worse. So hitting multiple targets with one systemic medication is highly beneficial.
But what if the spasticity isn't a widespread whole-body issue? What if it's just one stubbornly tight calf muscle that's pulling a child's foot down, making them walk on their toes, while the rest of their body's tone is relatively normal?
That's a really common scenario.
Right, so hitting their entire central nervous system with a heavy sedative like a benzodiazepine or high-dose baclofen just to fix one calf muscle seems like massive overkill. Like you'd be putting the kid to sleep in math class just to get their heel on the floor.
What's fascinating here is that the medical approach pivots entirely based on that exact distinction.
Oh, really?
Yeah, if only specific muscle groups are problematic, systemic oral medications introduce totally unnecessary side effects. This brings the team to rung 2 of the ladder, getting highly targeted with chemodenervation.
Chemodenervation. It sounds like a sci-fi weapon, but it basically means injecting localized treatments directly into the problem muscle to temporarily paralyze it.
Well, that is pretty much it. The primary agent given here is botulinum toxin type A.
Which most people know as Botox.
Right, exactly. Phenol and ethyl alcohol are also used as alternatives, though they work a bit differently. But when doctors inject botulinum toxin directly into that specific stubborn calf muscle you mentioned, the toxin physically blocks the release of acetylcholine.
Acetylcholine.
Yeah, it's the chemical messenger the nerve uses to tell the muscle to contract. So without that messenger, the muscle finally relaxes.
And the sources are very clear that this isn't just some quick cosmetic fix. These targeted injections are always paired with aggressive rehabilitative therapy.
Oh, absolutely. They have to be.
Because the window of relaxation gives the physical therapist a chance to stretch the muscle, build up the opposing weak muscles, and actually improve the child's gait.
And managing that localized tone effectively can significantly delay the need for major orthopedic surgery. It basically buys the growing child time.
But the mechanism is temporary, right?
It is. The nerve eventually sprouts new endings and resumes, sending the contraction signal. So repeat injections are usually needed roughly every 4 to 6 months.
Oh, wow. That often.
Yeah, sometimes doctors actually have to carefully time these, pushing them as early as 3 months, but they have to be super cautious not to induce resistance to the toxin, where the child's immune system literally starts fighting off the Botox.
Right. That makes sense. So we have oral pills for the whole body and targeted toxin injections for specific muscles. But let's look at a scenario where a patient has severe, widespread spasticity and the oral medications just aren't cutting it.
Yeah, that happens.
Or worse, to get enough baclofen into their system to relax their legs, they're experiencing intolerable side effects, like severe sedation, profound weakness, or intense gastrointestinal issues.
That scenario pushes the multidisciplinary team to consider rung 3 of the spasticity ladder, which is intrathecal baclofen, commonly known as the ITB pump.
Okay.
It is reserved specifically for generalized spasticity that is medically refractory, meaning the oral agents have failed or when the systemic side effects are just destroying the patient's quality of life.
The mechanics of why ITB is necessary really come down to pharmacokinetics. The sources explain that when you swallow an oral baclofen pill, very little of the active drug actually manages to cross the blood-brain barrier.
Right. And the blood-brain barrier is this highly selective protective shield. It's great because it keeps toxins out of the brain, but it also makes delivering neurological drugs terribly inefficient.
So you need a massive dose.
Exactly. To get enough oral baclofen into the spinal cord to reduce spasticity, you have to prescribe a huge oral dose, and that massive amount circulating through the whole bloodstream is what causes the heavy sedation and stomach issues.
Wow.
ITB circumvents the barrier entirely.
It's like installing a direct, high-pressure pipeline straight to the destination instead of relying on a slow cargo ship that, drops 90% of its cargo into the ocean during transit.
That's a perfect analogy. Surgically, it is quite literally a direct pipeline. A titanium pump, about the size of a hockey puck, is implanted under the skin of the patient's abdomen.
A hockey puck? That's not small.
No, it's pretty substantial. And this pump connects to a flexible silicone catheter that is tunneled under the skin and inserted directly into the intrathecal space, which is the fluid-filled sac surrounding the spinal cord. It delivers baclofen continuously, directly into the cerebrospinal fluid.
So because it's bathing the spinal cord directly, you achieve the therapeutic effect with a drastically lower total dose of the drug.
A tiny fraction of the oral dose. And consequently, the systemic side effects nearly vanish. The pump even contains a microchip, allowing doctors to program it wirelessly.
Oh, that's wild.
Yeah, they can deliver a steady baseline dose or program extra boluses of baclofen at specific times, like right before bed if nighttime spasms are a big issue.
And do they test it first?
Yes, to ensure it works, patients actually undergo a temporary trial dose via a spinal tap before they commit to the full surgical implantation.
But this isn't a magical maintenance-free solution, right? The reservoir in that abdominal pump runs dry and requires refilling via a needle through the skin roughly every 2 to 6 months.
That's right. It's a commitment.
On top of that, the battery in the pump eventually dies, meaning the entire physical pump has to be surgically replaced every 5 to 7 years. The sources also highlight some serious risks here. Complications are notably higher in growing children than in adults.
Very true.
We're talking about the catheter disconnecting, tearing, or becoming dislodged as the child moves around, along with a persistent risk of meningitis or wound infection.
It is a major ongoing medical commitment. The complications are real, which is why it sits on rung 3, strictly above oral meds and focal injections.
Let me push back on this strategy for a second. With all these surgeries, battery changes every 5 years, the constant fear of a catheter kinking, and driving to a clinic every few months for a refill, why keep refilling a pump?
It's a fair question.
Right. Why not just skip to a permanent fix? Surely modern surgery has a way to just solve the spasticity once and for all, so the child doesn't need a robot in their abdomen for the rest of their life.
There actually is a permanent surgical intervention, and it sits at the very top rung of the spasticity ladder. But its permanence is precisely why patient selection is incredibly strict and unforgiving.
Okay, what is it?
The procedure is called selective dorsal rhizotomy, or SDR.
Here's where it gets really interesting. Because unlike oral baclofen, unlike temporary Botox, and unlike a pump you can just turn off, SDR is a one-way street. It is completely irreversible.
Yes, SDR is a major neurosurgical procedure resulting in partial sensory deafferentation.
Okay, let's translate that.
Right, let me break that down. Spasticity is a loop. Sensory nerves send signals from the tight muscle up to the spinal cord. And because the brain is damaged, the spinal cord fires back an exaggerated continuous signal to contract.
Okay, I follow.
So, to break the loop, neurosurgeons open the spinal canal in the lower back. They identify the sensory nerve rootlets coming from the legs, and they physically cut or resect them. Typically, they are severing somewhere between 25% to 40% of these specific rootlets.
Wait. If a surgeon is permanently snipping 40% of the sensory nerve roots in a child's spinal cord, how on earth do they know which ones to cut without leaving the patient completely numb or paralyzed?
They utilize intraoperative electrical stimulation.
What does that look like?
While the child is under anesthesia, the surgeon isolates a tiny nerve rootlet and delivers an electrical shock to it. Then, they watch the corresponding muscle in the leg. If shocking the nerve produces a normal, brief twitch, they leave it alone. If shocking, it produces an abnormal, sustained, highly spastic response. They classify that nerve as part of the problem, and they cut it. They repeat this incredibly tedious, precise process, rootlet by rootlet.
That is wild. But because you can never put those nerves back, the ideal candidate profile is heavily restricted. The sources are clear. This is not for every child with CP.
No, definitely not.
The classic candidate is usually between 4 and 10 years old.
Mm.
And most importantly, they need to function at a GMFCS level of 1 to 3.
Right.
For context, the Gross Motor Function Classification System measures mobility. Levels 1 to 3 basically mean the child has some level of independent mobility, like they can walk perhaps with braces or a walker.
The criteria go even deeper into the patient's specific brain anatomy and motor control, too. They need to have minimal underlying weakness.
Why is that?
Because spasticity sometimes masks profound weakness. If you cut the nerves and remove the tightness, a child with weak muscles might completely lose the ability to stand. The specific etiology matters, too.
You mean what causes CP?
Exactly. The ideal candidate has CP caused by periventricular leukomalacia, which is damage to the brain's white matter, frequently seen in premature births, where the deep gray matter structures, like the basal ganglia, remain relatively healthy.
It's not just physical either, right?
Yeah.
The child's cognition and behavior matter immensely because the physical surgery is only half the battle.
Oh, it's just the beginning.
Right. Cutting the nerves permanently alters the patient's mechanics, meaning the child must have the cognitive ability and behavioral drive to participate in months, sometimes years, of intense, grueling post-surgical rehabilitation to relearn how to move their body.
And when SDR is performed on appropriately selected GMFCS level 1 to 3 patients, it is transformative. It yields ongoing functional gains throughout childhood, improves their walking stride, and critically, it protects against the severe functional decline we often see when these patients hit adolescent growth spurts and their bones outgrow their tight muscles.
But the sources also highlight a massive shift in how SDR is being utilized today. It's a whole new frontier. Surgeons are increasingly offering SDR to patients at GMFCS levels 4 and 5.
Right, which is a big change.
Yeah, these are patients who are heavily reliant on wheelchairs and require extensive physical assistance. The goal for them isn't independent walking.
For these severe cases, the medical goals shift toward maximizing comfort and care. SDR is utilized to achieve profound tone control to reduce agonizing joint pain.
And it helps the caregivers too.
Hugely. It is very much about caregiving ease. When a child's legs are scissored together due to severe spasticity, simply changing a diaper, dressing them, or safely transferring them from a bed to a wheelchair requires immense physical force. Releasing that tone changes their entire quality of life.
The sources show researchers are now comparing SDR directly against the ITB pump for this specific severe population. And early data is showing that SDR offers comparable tone control in the lower limbs, and surprisingly, possibly even better upper limb control and improved bladder function.
Which is amazing.
Best of all, it comes with lower long-term costs, and absolutely none of the ongoing device management, battery changes, or infection risks of an implanted pump.
I must add the caveat heavily stressed in the source material, though. Applying SDR in GMFCS level 4 and 5 cases is a newer practice. The long-term outcome data is still accumulating. The early evidence is highly promising, but the medical community is definitely still validating these results over longer timelines.
Fair enough. Now, SDR, Botox, and baclofen are entirely focused on spasticity. But cerebral palsy isn't a monolith. The narrative shifts drastically when we look at how medicine handles dyskinetic CP.
Right, totally different mechanism.
Yeah, instead of muscles being constantly tight, patients with dyskinetic CP deal with unpredictable, involuntary movements.
Dyskinetic CP fundamentally alters how a patient moves. It often presents as choreothetosis, which involves these involuntary writhing, dance-like movements, or dystonia, which involves sustained, twisting muscle contractions that force the body into abnormal postures.
That sounds incredibly difficult.
It is. The sources note that dystonia, in particular, tends to destroy a patient's function, limit their participation in society, and drastically lower their overall quality of life.
But here is the major clinical hurdle the sources highlight. Unlike the spasticity ladder, most treatment approaches for dystonia in CP haven't actually been validated by large, well-controlled clinical trials.
No, they haven't.
The medical community is largely flying on expert opinion rather than rigorous, randomized controlled evidence.
And that lack of trial data is a significant challenge. Medical teams are operating based on accumulated clinical wisdom.
So what do they use?
Well, when deciding what is given for dyskinetic CP, the oral medications often overlap with the spasticity ladder. They utilize oral baclofen, benzodiazepines, clonidine, and gabapentin.
Okay, so some familiar names.
Right. They also heavily rely on trihexyphenidyl, a drug initially developed for Parkinson's disease that blocks certain brain chemicals to reduce involuntary movements. And just like with spasticity, they use targeted botulinum toxin injections for specific, highly problematic dystonic muscles.
But what happens when the dystonia is severe and medically refractory? When none of those pills or injections stop the involuntary twisting? The sources detail a highly advanced surgical option, which is deep brain stimulation, or DBS.
DBS is essentially a pacemaker for the brain. Surgeons implant a pulse generator in the patient's chest. They then thread microscopic electrodes deep into the brain, specifically targeting the globus pallidus, or the subthalamic nucleus, which are the areas of the brain misfiring and causing the dystonia.
By sending continuous electrical pulses to those deep brain structures, it's literally trying to jam or override the faulty motor signals at their source.
Exactly.
But the sources point out this isn't a quick fix. Unlike waking up from an orthopedic surgery, the benefits of DBS can take months of fine-tuning the electrical frequencies to even appear.
It requires a lot of patience.
Plus, implanting hardware into the brain carries real perioperative risks, like bleeding or infection.
And patient selection for DBS is notoriously difficult. Not everyone benefits. If a patient with dystonia also has significant underlying spasticity, or if they have already developed fixed joint contractures where their joints are physically fused, they tend to be poor candidates.
Oh, I see.
The sources also specifically list myelopathy, which is any compression or injury to the spinal cord itself, as a major contraindication that predicts a very poor response to DBS.
Which perfectly illustrates why this is all connected. We've talked about manipulating the muscles, snipping the nerves, and shocking the brain. But the downstream victim of all these neurological issues, the spasticity, the dystonia, is the skeleton.
Yeah.
These abnormal muscle forces pull and torque on the bones every single day over a lifetime.
If we connect this to the bigger picture, the musculoskeletal burden of CP is massive. The medical team is constantly fighting against fixed contractures, where muscle shortens so much the joint gets permanently stuck. They are fighting against torsion, where the actual long bones of the legs twist under the pressure, and they are fighting against severe hip displacement and progressive spinal deformities like scoliosis.
It totally makes me think of checking a house's foundation.
Yeah.
The muscles are the framing of the house. If the framing is constantly pulling unevenly, warping and shifting, the foundation, meaning the bones, will eventually crack and warp under that unequal pressure.
That's exactly what happens.
But kids' bones grow so fast.
Father?
Aren't orthopedic surgeons tempted to rush in and fix the bones immediately before things get worse?
It seems intuitive to fix a crooked bone immediately, but the orthopedic approach is highly measured and conservative in the early years.
How early?
Before a child is around 6 years old, the focus is entirely on prevention. They manage the tone using the ladder we discussed. They rely on rigid bracing, and they focus on physical therapy. Major muscle tendon lengthening procedures or bone surgeries are rarely performed that early.
They intentionally wait until the skeleton is a bit more mature and stable.
Precisely. The surgeries are timed to skeletal maturity. Between the ages of 6 and 12, when the child's growth is more predictable, you start seeing targeted interventions.
Like what?
A classic example is a derotational osteotomy. If a child's femur has literally twisted inward due to years of spasticity, the surgeon will physically cut the bone in half, rotate it back into the correct anatomical alignment, and secure it with metal plates and screws.
Wow. But getting surgery isn't the end of the line, is it? There is a strict requirement for relentless, ongoing surveillance. Throughout childhood, doctors are constantly taking x-rays to monitor for hip displacement and scoliosis.
They have to be vigilant.
Because the risk for both of these skeletal issues scales directly with higher GMFCS levels, meaning the less mobile a child is, the higher their risk. If left unmonitored, a dislocated hip will cause excruciating pain and make sitting in a wheelchair just unbearable.
The skeleton is constantly adapting to the forces placed upon it, so the multidisciplinary team must constantly adapt their surveillance and interventions.
So what does this all mean? We have journeyed through a massive landscape of interventions today. We've looked at systemic oral medications that calm the nervous system and targeted toxins that paralyze stubborn muscles.
Yep.
We've explored continuous spinal fluid pumps, the irreversible resection of spinal nerve roots, deep brain stimulators acting as pacemakers for unpredictable movements, and the careful, timed surgical realignment of growing bones.
It really means that the management of cerebral palsy is the ultimate proof that medicine isn't always about a binary cure. It is an exercise in continuous reassessment.
Yeah.
You are managing a genuinely dynamic condition across a genuinely dynamic lifespan. It proves that maximizing the human experience requires the collective, relentless expertise of a dedicated team.
The X-ray machine might not offer a simple fixed or broken answer here, but the toolbox the medical community has built to manage this condition is incredible.
It really is. But looking at the trajectory of these treatments, this raises an important question. We're seeing the newest frontier of CP management shift toward highly advanced interventions, like deep brain stimulation and irreversible nerve surgeries, being used just to manage pain and improve caregiving in the most severe cases.
Right.
If we're already doing this, how might future advancements in neuromodulation completely blur the lines between technology and the human nervous system? Could we one day see smart implants that don't just blindly deliver continuous drugs or constant electrical pulses, but actively read the brain's faulty motor signals and rewrite them in real time before the muscle even has a chance to tighten?
A pacemaker for the nervous system that actually learns and adapts to the brain's signals in real time. That is a wild, incredible thought to leave on. Thank you for joining us on this deep dive into the source material. We will catch you next time.